is a monthly webinar which essentially focuses on some of the contemporary subjects in the field of urology. We invite people from all around the world to talk on some of the major issues confronting urology. We know that stone is a global problem. Stone is something that makes up anything from 50 to 70% of urological workload in our part of the world. The famous stone belt, which is essentially the Southeast America, the Northern Africa, Middle East, Southeastern Asia, up to Northern Australia, is the area which has a very high prevalence and a lifetime prevalence of about 10 to 15% stones. But however, things have changed dramatically in the last 1.5 decade, with metabolic syndrome becoming the primary cause of urolithiasis in the whole world. And it is not just the stone belt area. People living in Western world, in Europe even, they have a relatively high incidence of stone disease now. We all know what metabolic syndrome is, a constellation of various metabolic abnormalities which predisposes to urolithiasis. With the global high prevalence, urolithiasis is predominantly treated now by endourology, and with lithotripsy coming in the early 1980s, mid 1980s, and then followed by a huge leap into the world of endourology with percutaneous surgery, and now more recently ureteroscopy making big advances. So this has become the standard of treatment of most stone disease. Kidney stone, and particularly large stone burden, which is something that we see very frequently in our part of the world, is predominantly treated by PCNL. PCNL, if we talk about PCNL, there couldn't be a better person to talk about PCNL than our dear friend, Dr. S.K. Pal. Huge experience of this procedure and this disease, and he shares his experience all over the world. And today he's going to talk about a very pertinent subject, which is how to deal with the expensive armamentarium and how to economize this extremely important procedure, which, in my opinion, should be the bread and butter procedure for all urologists, at least working in this part of the world. With this brief intro, I first of all thank Dr. Pal for being here, and whenever I requested, he has always been forthcoming. It's always a pleasure to have him. He's just like part of our family. And Dr. Pal, the stage is yours. I'll just unshare.
Is my screen visible?
It is visible, sir.
At the outset, I would like to put on record my sincere thanks to Professor Hamad Athar, who has been a very good friend. We have been meeting in conferences, workshops all over the globe, and for having given me this opportunity of speaking in Conceptual Basic Course, which is organized by Section of Urology, Department of Surgery, Aga Khan University, and by the Karachi subsection of Pakistan Association of Urological Surgeons. So I extend my good evening to all of you who are attending this course, this meeting. And I always cherish my memories of coming to Pakistan 5 times and crossing the Atari-Wagah border twice, coming to Lahore, to Faizabad, then to Karachi, and twice to Rawalpindi also. 5 times I have visited, and I have very fond memories. In this talk, I have no disclosures to make. I do not promote or demote any companies. I am never on any panel of any companies. And whatever opinions I am going to express, they are my own. What I am going to talk today is how to economize treatment of urolithiasis in our developing countries. And I bring you greetings from Indraprasth Apollo Hospital, Delhi, and Apollo Spectra Hospital, Delhi, where I am working. I would like to dedicate this talk to those colleagues who are rendering their dedicated services in the periphery to rural masses. See, the stones have been there since ages, even 2600 years old, when Egyptians in Roman period, they were mummifying their bodies, and when we have done CT scans on those bodies of mummies, the stones have been detected. And the ancient textbooks of surgery, one book which was written in Sanskrit by Sushruta named Sushruta Samhita in 600 years ago, that has got a account of cutting for this stone. Similarly, Greek Hippocrates, in his book Hippocrates Corpus, there is an account of how to cut for these stones. And in first century AD, Cornelius Celsus, who was a Roman surgeon, he also has written about these stones and this stone surgery. I was going through this particular piece of literature as to what we are doing these days. What, as a doctor and in the hospitals, the work is being done. And it was a very interesting article which covers 369 diseases and injuries which all the hospitals treat in 2004 countries. And in last 29 years, what had been the global burden of all the diseases put together. And when we come to this urolithiasis, it is one of the most common urological diagnoses globally, with an estimated prevalence of 1% to 13% in different regions across the globe. In India, we don't have a robust literature or a confident statistics, but on an average, 9 to 10% of the Indian population is suffering from urolithiasis or is going to suffer from urolithiasis. And for that purpose, India and Pakistan are no different. We are only politically different, but otherwise, globally, means by geography and by race, we are the same. So if we put it collectively, India, Pakistan, China, and Russia, they take care of 50% of the stone disease of the world, and 20% of those occur only in India. And we are only 5,500 urologists in India. So not only the global incidence is increasing, we have been witnessing the change in pattern of urolithiasis also over time, as Professor Hamad just now pointed out. Earlier, we used to see about 30, 35 years ago, all our operation theater lists used to start with cystolithotomy of a small child. And even now, it is endemic. The bladder stones and lower tract stones are endemic, where there is a malnourishment, poor nourishment, and you see the vesical calculi. But those developed countries where overnutrition is there, where there is diabetes and obesity, which independently increase the prevalence of urolithiasis, we see small stones in the upper tract. So stones are increasing, and it is going to stay. They may change their presentation, their chemical composition, but urolithiasis is here to stay. And therefore, let us accept this challenge and continue to strive to train our future generations of urosurgeons to be better than us in managing urolithiasis with minimum pain, all success, and nil complications. I have been telling this motto of mine in different workshops and conferences organized in India. Then I must pass on. This is what I feel with the heart, that I must pass on the knowledge and skills which I have gained with all due dedication, honesty, and sincerity to others, so that these tricks which I could learn with hard work should not die away when I get buried, but they should continue to benefit mankind even after my departure from this mother earth. Now, what about the cause of stone disease? A European study says in year 2000, total expenditure or money spent on urolithiasis management was $2.81 billion. And this expenditure is increasing at 1.24 billion every year and will go on to continue till 2030 like this. So you can understand how much money is involved in managing the stone disease. And yet, thus, urolithiasis is a big industry, and everybody wants to make a share out of it for himself, be it industry, hospitals, doctors, or others. But in developed countries like India, Pakistan, and Nepal, in Bangladesh, urolithiasis is still the disease affecting economically weaker sections. I have yet to see a patient of Staghorn coming in Mercedes car. They always come, all those stone patients, they come either on cycle or in scooter. And from where this money trail begins, it is from our economically weaker sections only. So putting our hand on our heart, we must try to economize treatment of urolithiasis by all means. Now, armamentarium, which you are going to buy in the beginning itself when you want to start endourology or PCNL at your center, PCNL being the cheapest, the best operative modality for removal of stones, let us concentrate only on that. You need a OT table, you need a CM image intensifier, you need lasers, you need irrigation pumps, which are all coming through industry at a very higher cost. This particular Euro table, which has got pivoted at one side only, and the whole this area is free for imaging. This is all radiolucent area with different attachments and with the remote control and tilting right and left everything, which is costing somewhere around 20 to 30 lakhs of rupees in India. Is it really worth it? Do we need it? If I remember in 1984 and 85, when I learned PCNL, many centers, particularly in Pune and Mumbai, they were doing PCNL in the X-ray departments under local anesthesia in 2 to 5 sessions under this fluoroscopy tables, where in the morning barium meal, barium enema studies were being done. Because CMs were not freely available and we were able to manage. And when that time in 85, I was working in Kasturba Medical College Hospital, Manipal. And there, when I wanted to start PCNL in 1986, all operation tables in the theater were having a centrally mounting table. And this was all made of stainless steel. There was no possibility of using CM or seeing through these. I was hesitant to do PCNL in the X-ray department under fluoroscopy table. So what I did was I designed this table of PCNL in the motor garage of KMC Hospital Manipal, where this labor table was thrown in the junk, and just what I did, got this particular top changed. This was a 3 feet by 2 feet board with the sun mica laminated. This is a 1 feet by 2 feet, and this one is 2.5 feet length and about 2 feet width. So these three boards were laminated on this, and you can see between these four limbs, these four legs, there is a beautiful, nice movement of the siam, and you can see from xiphisternum to the pubic symphysis of almost everyone, so that PCNL could be done very easily on this table. And my first 700 PCNLs I did only on this table without any fat and fancy. And I still recommend. This table would have costed me at that time only 7,000 rupees, and my salary was also 14,000 rupees. Now also, I think you will be able to make it in about 15 to 20,000 rupees. And this table works very well. You can bend it like this, put the lithotomy strips over here, and do a ureteroscopy. You can do a stenting. You can put the ureteric catheter, and then turn the patient prone and do PCNL in this. Now, do you need a CM, expensive CM from Japan, from Germany, or from other countries with so many memories and so many things? No. We need a very simple CM for PCNL. And in India, we have a two CM manufacturers. Then the CM costs somewhere between 6 to 10 lakh of rupees. The only thing which you should see when you are going to buy CM is that the patient table, patient's whole thickness has to come in between these two, between the X-ray tube and image intensifier, and there should be a good working distance. So when you are going to buy a CM table, CM machine, you should see that there should be a distance from X-ray tube to the image intensifier of at least 30 inches. Only a single frame memory and a 9 inches diameter image is what you need for a successful PCNL. And CM is the only expensive tool which anyway you will have to buy when you are going to start PCNL. About lasers. This is a little sensitive issue. Do we need expensive laser and laser fibers for PCNL? And the question is, what are you planning to do? If you are interested in doing a miniaturized PCNL, if you are interested in doing a miniaturized PCNL, this particular 12 French nephroscope is the most popular, most versatile, and very efficient tool for miniaturized PCNL. And through this 12 French nephroscope, which is available by different companies, they have a 4 French working channel through which easily you can pass 0.8 or 0.9 millimeter lithoclast probe. So you don't need this laser fibers and a laser energy to break this stone when you are using a 12 French nephroscope. And only thing is when you pass this probe, the irrigation fluid will become less, the irrigation speed will become less. So you will have to pressurize your this irrigation. Otherwise, it is very much easily possible using this scope without the lasers. Yes, micro PCNL, which was to be done through 4.8 French needle, and ultra mini PCNL, which is done through 8, 10, or 12 French cannula or through 12 French Elkin cannula, is no more widely acceptable. And now most of us have given up in favor of RIRS because in this particular ultra mini PCNL, you can only fragment this stone, you cannot take it out. And fragmentation and leaving you can do even with ESWL or with RIRS. So you don't need these instruments and you don't need the laser for using ultra mini PC. So overall experience of miniaturized techniques of PCNL has taught us that the middle path appears to be the best. PCNL tract should not be too small that stone particles cannot be removed and double J stent cannot be put. At the same time, we have to dust the stone, and we just leave it there. This our path should not be so small that we leave it there. And free irrigation is also not possible when this track is very small, and that will cause rise of intrapelvic pressure. At the same time, PCNL tract should not be too big that it causes significant bleeding. So the track size which you need is somewhere 14 to 22 French because now 20 French nephroscopes are easily available from different companies, and therefore you need most of the cases only 14 to 22 French PCNL track. And when you are using this much size of track, laser is not required. So laser is not required for PCNL largely. And similarly, the pressure irrigation pumps, costly pressure irrigation pumps are also not desirable because once you put the pressure on, the pressure pump will go on generating the same amount of pressure and go on pumping the same amount of pressure inside the pelvic ileal system, which can lead to the septic complications. Instead, this particular indigenized pressure pump using this particular bulb of the BP apparatus is very useful. When you pump it 3-4 times, there will be higher pressure, but gradually some water, when it drains, the pressure will automatically get reduced. So according to your need, you can just ask somebody to pump in, and this pressure pump is almost negligibly inexpensive. So there is no need of using or buying the pressure pumps for PCNL. Now, how to economize the technique? You have a minimum equipment of a small table, which I mentioned. Expensive C-arm costing 6 to 10 lakhs. You don't need lasers. You don't need pressure pump. Further, the technique can be economized by doing the procedure under spinal anesthesia. Tell your anesthetist, be confident, tell him that giving the spinal and putting the patient prone is practiced all over the world, particularly in India, Nepal, Pakistan. So there is nothing to worry. They should not run away. They can give spinal and patient can be put prone. Yes, if they add in the bubovicaine some amount of fentanyl, the anesthesia can work up to 2 hours, 2.5 hours, and easily you can manage the PCNL. Even supracostal punctures can be managed in the prone position under spinal anesthesia. Not only that, spinal anesthesia is so good for PCNL because patient is alert and communicative. When you are turning side, he also participates. Oxygen saturation is best in prone position. This was known during our COVID period. All COVID patients, we used to nurse them in prone position. Oxygen saturation used to be good. Complications are easily identified when you are going through the uh, supracostal, transpleural, transdiaphragmatic route. Because diaphragm is innervated C4, patient himself tells that there is a pain in the shoulder, and you come to know that you have gone a transpleural, transdiaphragmatic. In GA, you will not come to know. So in spinal, everything is much clearer, much comfortable. Post-operatively, also patient comes out smiling. He is not shivering. He is not having a desire to pass urine again and again. A patient with general anesthesia in PCNL, when he comes out of anesthesia, first thing he will tell, either he is shivering or he is having a difficulty in breathing or he is restless, and he tells that he wants to pass urine. All those things are not there. Patient comes out smiling, and spinal anesthesia is too good for PCA. Coming to the guide wires, there are so many guide wires available, and I see most of the places now Terumo guide wire is being used, which is technically made of a hydrophilic coating is there over tungsten polyurethane jacket, and there is a super elastic nitty core. All this is going to be expensive. But what I prefer out of so many expensive guide wires is cheap and best guide wire, PTFE coated stainless steel angiographic J-tip guide. This is angiographic guide wire which was used inside the vessel. So it is a very good, very smooth, and there are two types of guide wires, straight tip and J-tip. I always prefer the J-tip because when the patient comes to us, many a times he is having a edimeter system and a straight tip guide wire may even go out. Sometimes the straight tip goes and makes a submucosal tunnel like this. While J-tip is so good, as soon as it comes out of the needle in the pelvic ileal system, it takes the shape of a J. And then this particular J, it is proceeding forward in the pelvic ileal system. You can see this in this video that when the J is progressing forward, there is easily it is going smooth way. So you come to know by the smooth passage of this J tip that you are in a dilated pelvic ileal system, open system, and this free unobstructed movement ensures that we are in PCS and we have not perforated and gone out. So all this is obtained by J-tip. It doesn't perforate and doesn't go out. Coming to dilatation of the track, there are so many types of dilators are available, but my preference of cheap and best is Teflon telescopic dilators. These are my choice. In India, they cost somewhere around 400 US dollars. and then they last for at least 400 cases. So maybe only $1 per case is the expenditure out of your pocket. They come in four sizes: 12, 18, 24, and 30. Wherever you want to stop, like if you want to make a track of 14 or 16, just over the 12 French dilator, you pass the implant teeth and you are good to go. If you want a track of 20 to 22, which is the most common track nowadays, you have to make just two dilators, use 12 and 18, and pass a implant teeth of 20 or 22, and you are good to go. So like this, and particularly one good thing about telescopic dilators is that once you make a hole in the kidney, and if you remove the dilator, the parenchymal injury in the kidney starts bleeding continuously till the next bigger size dilator comes in and blocks or tamponoids. In telescopic dilators, that is not the case. One dilator, over that another dilator, and over that implant sheath. So tamponade is continuously monitored, is always maintained, so that there is no chance for the parenchyma to bleed. Therefore, metallic alkane dilators are also telescopic dilators, but they get damaged even if a one dilator falls and the tip gets damaged, it won't slide over the previous dilator smoothly. And then the whole set has to be replaced because they don't give individual dilators. So Teflon telescopic dilators are cheap and best. Serial dilators and step dilators, they cause more bleeding because they are step by step. You have to remove one, then till the next one comes in the place, the kidney parenchyma is bleeding. And the biggest advantage of serial dilators is there is such a long, about 10 millimeter long beak. So when a case is there where the stone is right up to the periphery, and if you dilate, the tip is touching the stone, and dilatation actually has been achieved only up to this. So when you put the implant sheath, it will stop here. And this much portion of the renal parenchyma remains undilated and continues to bleed. Therefore, if you want to push this peak inside, you cannot break the stone, but you break the kidney. So therefore, a long conical tip and step dilators are not very good technically. I use these Teflon telescopic dilators, which have got a distance of only 2 to 3 millimeter, and here is the maximum full dilatation, so that you reach right up to the stone when you use these dilators, and they are very economical. You come to this clinical situation quite often when there are multiple calcial renal calculi. And many of our European friends, particularly French people, they will always tell ECIRS, and they will tell you to do a RIRS in these cases. But in this, I have a different point of opinion. I don't try to use flexible nephroscopes or expensive nitinol baskets and lasers in such situations also. Rather, I teach saline push technique. This saline push technique is just the concept of repositioning of stone fragments by saline jet to more favorable position from where you can pick the stone up. I will give you a few examples of this technique. This is the basic behind it. Whenever there is a large staghorn, or if there is a PUJ or a ureteric stone, the whole pelvic calycial system dilates. Even the infundibuli also get dilated, and there is a hydrocalyposis. Now, if there is a stone like this, you make a track from here, and if you remove the whole stone, now these stones which are lying in the calyces, there is no need to do a ECIRS or to pass a flexible nephroscope. You just put a needle from here, put some saline jet, and this stone will come in front of you, and you can take out this particular stone from the same implant sheath which you had made. So you can make many small punctures, all these small punctures of 18 gauge needle through the this initial puncture needle are not going to harm kidney. They are not going to take long time, and you will be successful in removing almost every stone from different portions of the kidney. Only such situation when the infundibulum is really narrow, like if there is a tuberculosis, and then if you go on pushing with saline, the stone will not come out, and you may have to make another track. So these are the only situations where you will require another track. Otherwise, most of my cases are I make a implant sheath one track, and all other calyces in the kidney, they are just flushed with the help of a needle puncher and flushing, and all the stone particles they come in front of you, all these secondary stones they come in front of you in the renal pelvis, because water drains through the passage of least resistance, they come in front of you and you just pick them up. Like this case which was full of stones, now in this case I removed, made two particular implant sheets were placed. You can see this is recorded with the help of a smartphone video, not very clear, but you can make out these stones were not coming out of this. So this is an insert. You can see I am injecting with this saline, and when I inject this saline, these stones they come in front of me. They come into the renal pelvis, and then I can pick it up easily. All these stones are lying here. Now this particular stone, which is little stubborn, trying to manipulate it all around. You can see my hand movements over here, trying to dislodge it from all around, then coming to this periphery to the lateral border of the stone and then pushing the saline. But this stone is not budging. In spite of pushing 2-3 syringes, when it is not coming out, I will put some contrast and see what is the width of the infundibulum. It appears to be okay. So then again with greater enthusiasm, I put some saline, wash away all the contrast, and now this stone also has come out. So all these stones which might have required a nephroscopy, a flexible nephroscopy or ECIRS, they can easily be removed. This stone bulk, they are in different calyces. One stone is here, 3 stones are here, and 1 stone is here. You cannot do a ECIRS through particular such a small thin PUJ. And then it is better to bring all the stones together in the renal pelvis by needle punctures and then make a track and remove all these stones. You can see this video again. This was being done in one of the Percons, one of the operative workshops. So this particular calyx harbors this stone. First of all, I will, after putting contrast, I will just puncture this particular calyx which was harboring this stone, and then flush it well, bring the needle tip at the periphery and then push with the saline. That stone has gone into the renal pelvis. Now make a track where there were 3 stones. After making track, you can take out all these 3 and 4 stones, whichever can come out of this particular track. And then when you see there is a radiopaque shadow over here and 2 radiopaque stones over here. Again, make a second puncture over here, bring the needle tip at the lateral border and give a saline push. They came in front of you in the renal pelvis. Now do the nephroscopy and you can remove those stones. Lastly, this particular radiopaque shadow, puncture that and put some saline. When I put some saline, this gets disappeared. So it was not the stone, it was just the dye which was there in that particular. So now there are 3 punctures and 1 track, and all these stones which were in different calyces have been removed. It just takes 5 minutes and there is no lengthy procedures, no lasers, nothing is required. All this stone bulk has been removed. But if you see through this supracostal puncture, but this particular stone is not coming in front. So what? This was another Percon where I did a puncture on the lateral portion of this stone. Then checked in 30° and 0° that my needle is at the lateral border of this. It is a stone guided puncture. And then you take out this implant sheath little bit outside so that the space gets created. It should not block the infundibulum from where the stone is going to come out. And now when you take out this, you can see that implant sheath is being withdrawn. And now when you push this with this saline, the stone is moving towards the implant sheath. 2-3 pushes and it comes in the mouth of the implant sheath. One more push. And then when you see, the stone is in front of you. So you take out these stones. The only thing is you should learn how to make a good puncture, and you should know how to push the saline, and then the stone will come out. This is the view how a needle which is pushed from side. Entering this particular calyx would have been difficult from this particular implant sheath entry. So pushing with the saline, and now you can see how the needle looks like, and now you can remove the stones. Now this is by Dr. Sanjay Khadgi. He sent me his first case. There were 2 stones side by side. One stone has been removed. The other one is in the adjoining calyx. So he has punctured this particular calyx. Now he has made one push with the saline. It comes to the pelvis. Second push, it comes in front of his implant. So this is all what you have to learn, and then there is no need of expensive tools, expensive modalities, and therefore I'll give you a take-home message. 90 to 95% of surgeries for urolithiasis, PCNL, can be done with simplest armamentarium, making 14 to 24 French tracks. And believe me, 14 French tracks, they don't bleed. So you should not be worrying about too much of bleeding complications. You should have 2 nephroscopes, one of 12 French, one of 18 to 20 French. That is all is required. And then you can easily do the most of the cases without expensive armamentarium. You should learn saline push technique, and there is no need of spending lot of money on flexible nephroscopes, lasers, ECIRS, expensive C-arms, fancy OT tables, and pressure irrigation pumps. These are not mandatory. They are only out of fashion. This particular stone, if it would have been done in the cross renal ectopia, so many stones in the lower calyx, middle calyx, superior calyx, and in the pelvis. This is the cross renal ectopia. So in this case, this was my case only. I made a puncture from here, picked up all these stones, and then saline pushed these 3 particular calyces and all these stones. This was the track made. This was the implant sheath placed, and all the stones, they were pushed into the renal pelvis from here, here, and here, and all the stones were removed then and there in one go within a very reasonable time. So all urosurgeons should dedicate themselves to learn the technique of PCNL, because for generations of urologists, we are going to utilize this technique for removing stone. It is 40 years old technique. It has stood the test of time. It has taken the challenges of ESWL as well as RIRS, and still it is one of the very successful technique and very economical technique, very useful for our developing countries, and it will really serve the mankind in most economical way. Thank you very much for listening to me so patiently. And I invite all of you to participate in PERCON 2024, which is my 11th International Live Operative Workshop, where with all dedications, with about 6 to 7 international foreign faculty and about 100 national faculties, we try to teach, we try to interact with everyone and try to teach them the intricacies of PCNL. If visa comes as a problem, you can join in as a viewer on this particularly for the internet viewing. We will be giving the link later on. Maybe by September 15th, we will start distributing that link. So you can see on your laptops all the whole workshop you can attend. Thank you very much, and most welcome to have participation in PERCON 2024.
Thank you very much,
Over to
Dr.
you,
Paul.
sir.
As always, a wonderful talk. And with your permission, this talk will be made available on the PAUS Karachi chapter website for people, because people have expressed that they would like to keep consulting to this talk whenever they start off doing PCNL and improving the techniques of PCNL. There have been some messages. Most of them have really appreciated the practical value of your talk and the tips and tricks coming from the vast experience that you have in this procedure. Has come from the Karachi chapter president, Dr. Shahzad Ali, from Shabi Ahmed, who is the urologist particularly interested in PCNL. He works in Birmingham. There is a question from Mohammed Naseem, and he wishes to know if there is an issue with the loss of anesthesia during PCNL performed under spinal anesthesia. What is the way out? So if the anesthesia is running out and the patient start feeling pain, what is the way out?
The PCNL is the only technique which can be stopped anywhere at any stage. Whether it is needle puncture, half dilatation, half removal, or any stage, you leave the nephrostomy and come out. And second visit is always much better, much comfortable, and very you really feel if you are really finding difficulty, any difficulty whatsoever, bleeding or you are losing the track or anything. If you do second sitting, you will realize how easy it is, and you will wonder what happened in the first sitting. So if your anesthesia is running out, there is absolutely no worry. You just put the nephrostomy tube, leave a tube to whatever level, and then come again. Secondly, although it is heroism, because the patient is in the prone position, one of our anesthetists was so confident that he will do a second spinal puncture. It is not mentioned anywhere. He will do a second spinal puncture if 2 hours have finished, and if we want to continue under prone position only. And he was so good under C-arm, he will see space in between, and he will put a needle in the spine and then inject some more bupivacaine. And he could give, it has happened 3 times with us. But no, anyway, it is not mentioned in literature. It is just the heroism. So that is also possible. We saw it being done.
Thank you. There's another question. I know that you are a big fan and you've done both supine and prone. There's a question about your personal preference, and is there any real stone clearance difference between the two ways of performing PCNL?
So it depends upon the technique of PCNL or initial puncture you are used to. If you are used to making a track under bullseye technique, where you have to go in the center of the back, and if it is under 90 degrees, your track is vertically oriented, you are entering like this, then turning to supine and doing a bullseye will be impossible. What I have been teaching all through my life is entering the kidney through the convex border of the kidney and through the lateral surface. So if I have to come through the posterior axillary line, it doesn't make any difference whether the patient is supine or he is prone, because anyway I am coming from the posterior axillary line. So for me, technically, there is absolutely no difference whether the patient is lying supine or prone. And therefore, whenever the anesthetist feels compromised, he needs a better access to the airway, particularly kyphoscoliotic patients or COPD patients. I very easily do a supine PCN because I have to come through the posterior axillary line. It doesn't make a difference whether patient is like this or like this. In supine, you cannot do a bullseye puncture.
Yeah. There's another question about the saline push that you have described, and I know that you use the needle to push the stone and saline push another. You mentioned that the infundibular, narrow infundibulum is one contraindication to this technique. Is there any other contraindication? Is any other situation where you would not do this?
Sir, the infundibulum is not always in the same straight line with the renal pelvis. Sometimes there is a calyx is here and infundibulum is going like this. So even if it is wide, when you push, this stone will dance in that particular calyx, will not come out of the infundibulum. So in
Yeah.
such situation, I will do a dilatation only up to 12 French, or just pass a Elkin cannula, and through the ureteroscope, you can see in that renal pelvis, in the calyx, and then with the under vision, you can just make the stone jump over that particular hurdle or angulation of the infundibulum, and it will go inside the renal pelvis. So just passing a needle, guide wire, and Elkin cannula. In Elkin cannula, pass the ureteroscope, and with the ureteroscope, you can even little bit fragment the stone also, and main bulk of the stone can be passed over through the infundibulum into the renal pelvis, where already your implant sheath is positioned from any other calyx. So you can easily remove that.
Great. I don't see any further questions. Let me just recheck. Yeah. So thank you again, Dr. Pal. Always a pleasure to have you, and hope to host you again in our future meetings. Have a very good evening, and thank you very much.
Thank you very much, sir. And thanks to all the listeners, and bye-bye to all of you. And I would love if you attend Percon. And the last time, I think in Peshawar, this I gave a link, and in the auditorium of the hospital, through that link, they displayed it, and then many people were benefited by that. So I would love if somebody learns from these operative workshops. It will be good. And this PCNL is a very good technique, should be spread out to the real peripheries, where main bulk of our population lives, and they are really suffering from stones, and this easy and cheap technique should reach to each and every. Thank you very much, sir, for listening.
Thank you very much, and a very good luck with your meeting in
Good night.
Percon. Take care, sir. Good night.